All right, we're going to go ahead and get started. Welcome everyone to the Simon Searchlight Virtual Family and Research Conference for HIVEP2 families. We're very glad to have you here. Our first presentation is going to be a Simon Searchlight HIVEP2 registry update by Dr. Wendy Chung. Dr. Wendy Chung is an ABMG board certified clinical and molecular geneticist with over 20 years of experience in human genetic research. She's the Kennedy Family Professor of Pediatrics and Medicine and the Chief of Clinical Genetics at Columbia University, the Director of Clinical Research at Safari and the Simons Foundation, and the Principal Investigator for Simon Searchlight. So here's her presentation.
Hi, my name's Wendy Chung. I'm a medical geneticist and pediatrician, and here to tell you today, as part of Simon Searchlight, about HIVEP2. So the data, the information I'm going to share with you today comes from a study that we've been doing for about a decade that's called Simon Searchlight. So let me start by explaining what this is part of. And for any of you who have been part of this, we thank you very much for participating. And as you'll see from some of the information I'm going to show you, I think we can learn a lot more from each other. And so if any of you want to participate, I'll be showing you, but you can just Google Simon Searchlight. Then it'll take you right to the landing page, and you can look at the genes we study about midway down the page and look at HIVEP2. So as we do this, Simon Searchlight is an international study, and what we're trying to do is very much learn from each other. It's all about 150 different genes, or what we call copy number variants, that are associated with autism and related neurodevelopmental disorders. Most individuals who are part of the study are just like you. They've gotten their genetic diagnosis largely from the medical system, from one of their providers, a geneticist or neurologist, and they've found a community, sometimes a community on Facebook, sometimes a community online, and then join this study so that they can answer some of their unanswered questions about what does the future hold? Are there certain things that I should be watching for in my child? Are there things I can learn from others about what's worked for them, either medications or therapies? And so what I'm going to be sharing with you today is information that other families have shared with us. And as part of this, we're very much dedicated to giving that information back to the community, back to any researchers who can use this, so that we can grow together, that we can stand on each other's shoulders to understand HIVEP2 better. As we do this, we appreciate feedback. So if there's something that you didn't hear, some questions that you didn't hear answers to, we would love to know what the gaps still are so that we can continue to iterate and design this study in a way that's meaningful. The other thing I'll say is that you'll notice as I talk about this that all of the information is de-identified. What that means to me is that no one's name is associated with this. You'll see generally some information that says, for instance, how many boys, how many girls, what the age of people are that are participating. But again, you're not going to see any specific information about where someone lived or their zip code or anything like that. So as I was stating before, we've been at this a long time. As we started doing this, we learned, and I think we made things better. One of the things we learned early on was that we had communities that were growing. As diagnostic testing, as genetic tests has grown around the world, as it's become more accessible, we realized that we need to make this as easy as possible for people to participate. So this is now all completely online. When we started out, we had people actually come to specific centers, and we were hearing that that was burdensome. It took time off from work or school. People had to travel. So increasingly, and now entirely, we've done this online. This is possible from anyone in the world to be able to participate. And we have translators as well as genetic counselors who work with our families that are fluent in many, many different languages. And we try and make it, as I said, possible for people to participate online, in their pajamas, on the weekend, at 11 o'clock at night after the kids are in bed, whatever we need to do to make it as easy for you as possible. I'm going to walk you through the types of information we collect, and I'll say that when I'm talking about this today, I'm not going to talk about all of this information, but we set this up so that families, as they're participating, We try and get what we find to be the most valuable information for other families first. And over time, there are things that are more detailed and helpful, especially to researchers. So all of this is helpful to someone, but we've tried to sort of front load the things that families find most useful to each other so that we can make sure that we're generating information that you can use. For the most part, we're focused on the individual with the specific genetic change, so HIVEP2 in this particular case. Then that's that first column that I'm showing you. This column here with all the X's, those are all about the individual with HIVEP2. And one of the important points that I want to make is that this is a longitudinal study. So what that means to us is that we get information from someone at the time they first register, but we want to see how our kiddos are growing up over time, how they're changing, which things are getting easier or harder, and certain things, for instance, when they change when someone goes through puberty, we might know if your child's only 5 years old, so we need to actually watch them as they're growing up, as they're going through adolescence. And then ultimately, one of the things you'll hear me say many times is that we're limited in what we know because we don't have many people in the community who are, for instance, 30 or 40 or 50 or 60 years old. So one of the things that we're very much committed to is that we're here for the long term. We're here with the community, we're here to continue learning, and we want to grow up. We want to be able to support your children and your families as they grow up because there are different challenges at different life stages. So the information I'm going to be reviewing with you today is largely information that comes from the telephone interviews. For those of you who have been part of this, you know that we have, as I said, genetic counselors who talk with you about your child's history, everything from before they were born up until the present day. And as well, we also try and get a sense of how they're developing. If there are particular domains or particular areas that are especially easier or potentially more challenging. And we're trying to highlight that in part to understand what are areas, what are educational strategies, special educational therapy strategies that might be more effective. And while I don't have all those answers yet, that is what we're going to be building towards in the future. As we're doing this, I want to emphasize that we've listened very much to you all as parents. And so a couple of the instruments that we've built over time, some of these online surveys, were directly the result of family members, largely moms and dads, who told us either about things that they were expert in, and because of some of that professional training, they were noticing in their own children or other members of the community, or for some parents as educators, they were realizing as they were seeing how their children were learning things that might be unique and specific to those groups. And so as an example, we've added things like dental surveys with some of our parents who are dentists or who are interested in oral health, oral medicine. As I said, some of our parents who were educators that were thinking about how you can teach a child to read. And I'm sure we're going to continue expanding this list over time based on your feedback. So do please be generous with that feedback. Okay, so some specific information that we've been collecting through Simon Searchlight on you in the community. So the first thing I'll say is that we have individuals who have started this process, but not everyone has finished the process. And so if you can remember registering at some point and you haven't quite gotten through to what we call the medical history or talking with the genetic counselors on the telephone, I encourage you to go back. If you've forgotten your password, you can easily log in and try again. But what I'm going to show you today is that we've got information. This is based on a relatively modest number. It's actually only 12 individuals who got through to the point of telling us about this. 5 females, 7 males. And again, as I told you, the age range is still skewed towards younger individuals. Although we do have one individual at 42 years of age, we're definitely skewed towards individuals even less than 10 years of age. So 32 individuals started the registration process. The first step in this process is that we ask you to show us a copy of the actual laboratory genetic test report. We're doing that because believe it or not everyone who comes to us with a diagnosis is that really truly their correct genetic diagnosis. I would say when people read a lab report and read something like HIVEP2, 95% of the time, you're in the right club. This is the right answer. But every once in a while, we appreciate that there may have been some either incorrect communication from the laboratory or the geneticist or the doctor, or quite frankly, just some information that's not really well understood. And as over time, as we learn more about genetics, it becomes clearer to us what this means. So of the 15 or of the 19 rather individuals who submitted their laboratory reports as an example, the majority, but not 100% of people, we actually believe their diagnosis is HIVEP2, and those are the individuals that we then invite to go on to do the medical history interview. So for those of you who might be interested in some of the genetic gobbledygook, um, this is what I'm sharing. These are the results that we get from the laboratory reports. This is also probably even more useful to researchers in the field. And so I'm putting this out here because, again, part of what we do in Simon Searchlight is to make this information freely available to the research community so that they don't have to continue, they don't have to bug you, basically, to understand how your individual and your family is doing. This is something where we can ask you once, and we can be able to use this across potentially dozens of research studies. As part of this series, you've been learning about how to read your genetic test report. So I'm not going to go into detail about that, but to say that what I have shown here is when there's a number in parentheses. This was something you didn't get in that primer. This means that 3 individuals in the community have this same exact genetic change, the arginine in position 943, or 2 individuals with this change, or 2 individuals with this change. And so that means you're not alone. On the other hand, one of the things that I also want to highlight is most of the genetic variants that we're seeing here, they are single individuals with these change. So everyone, if you don't see a parenthesis after that different genetic variant, it is the only person in the HIVEP2 community we see with that change. Why is this important? For most of you, you are unique. And as a unique person, it means you really have to represent yourself, or your child really has to represent themselves, because it is possible that there may be differences based on the underlying genetic change. And so one thing that researchers are doing is they're comparing and contrasting individuals that have different genetic changes to see, do they seem to act in the same way? Might there be differences? And if there are differences, once we start looking towards treatment in the future, will we have to consider these differences to tailor treatments based on the genetic differences within the community? My guess is that everyone is not going to have their own very special treatment. There are going to be enough similarities amongst many people that we're going to be able to use similar treatment strategies across different genetic changes. However, if you want to make sure that researchers are working on the genetic change in your family, you have to represent yourself by signing up for the studies, by working with researchers, in some cases donating a blood sample so those researchers can work on cells from your specific change, but you have to represent yourself. We're trying to do this in a way that, as I said, is accessible, that everyone can represent themselves and hopefully do so with minimal burden. I know right now we're in a pandemic that none of us could have predicted, and it's all much harder to just get a lot of things done. But otherwise, when this eventually lifts, I hope it will be easy for participants to do things like give a blood sample if they want to. So let me now do a deep dive into the medical information that we know that you've provided. Again, just as a reminder, this is based on 12 individuals, mostly children, although we do have a hint at what's starting to happen for adults. Okay, so one thing that I'm going to say at the very beginning, and I'll say it again at the end, is as far as we can tell, this is largely a condition where we see above the shoulders. It's not entirely, and I'll explain what I mean by that, but it's largely a condition that affects the brain. The way the brain affects the rest of the body is why we see some of these manifestations, but it's largely a neurological condition or largely a brain condition. And it's largely a stable condition. And let me pick apart what I mean by that. What I mean is that it's not a degenerative condition. It's not as if we see children regress. It's not as if we see individuals fall back or lose skills over time. In general, we're seeing children as they're growing up continue to gain skills, continue to improve and be able to do more and more over time. but it takes patience. It takes sometimes repetition. It takes being able to focus on particular skills and try over and over until they finally get drilled in. Once they are solid, once those skills are really attained, we're seeing individuals retain those skills. Now, I know some of you are saying to yourselves, well, goodness, for my son, my daughter, my granddaughter, my grandson, um, before when they were in school, pre-COVID, they were doing these things, and now we've gone to this remote learning and online learning, and it feels that they've lost some of what they had. I appreciate that. And I think you are right that without having that repetition, that reinforcement, that usual school situation, I do think you're right that some of the skills that weren't quite solid, they were close, but they weren't quite solid, we may not have finally achieved. But I do think we're going to get back to a time when we will be back at achieving those skills, and I don't think these are going to be permanent losses. The thing that you see that's common to everyone is that everyone in the community has some sort of issue in terms of the way their brain is working. Depending on the age, this can be classified as developmental delay. They're delayed in their milestones like walking and talking, reading and writing, things like that. When children get older, we formally call that same sort of descriptive process, we call that intellectual disability. So whether it's developmental delay or intellectual disability, we're seeing that the majority of individuals have issues like that. For some individuals, they are having problems in terms of language very specifically, either language impairment or being minimally verbal. Those are very similar sort of related things. And some of them, in addition, can have particular behavioral challenges. So these are descriptive terms in terms of how they behave. And not to say that they don't have HIVEP2, they have HIVEP2 as an underlying cause of why they have behaviors that are on the autism spectrum, or why they have behaviors that are related to anxiety, or why they have behaviors that are related to attention deficit hyperactivity disorder, or ADHD. As you can see, again, these are small numbers, but every one of the children or young adults has one of these, at least one of these. And as you can tell by adding up the numbers, because they add up to more than 12, they add up to more than 100%, many individuals have more than one of these conditions or more than one of these behavioral issues. That's the most of what we see. There are a few other things that we see, and I'm going to highlight and try and frame these in what I call news you can use. So information so that you can make sure to stay on top of things. So if there are issues with the way the brain's functioning, one important thing to do is to make sure that all the information coming into the brain is getting there in the clearest way possible. So what I want is I want the senses to be working 100%. I want people to be able to see clearly. I want people to be able to hear clearly so that they can get all that information coming into the brain in the most accurate way possible. Why do I mention this? Because not everyone can necessarily see or hear clearly, and we need to take away those blockers. And sometimes our kiddos can't tell us that they're having problems with seeing or hearing, so we have to be proactive and we have to stay on top of this. So for the most part, I think there are some things that parents appreciate. They can see if there seems to be a lazy eye or if it seems like the eyes are crossing. And so those are things that we find that parents very commonly go in to get checked. What I would say, though, is we need to be proactive in the sense that every child, at least at baseline, needs to have their eyes checked, ideally by a pediatric, or if your individual in your family is a child, by a pediatric eye doctor or ophthalmologist, especially one that knows how to deal with children with special needs. You know, our kids can't necessarily read the eye chart to read those letters and to be able to check how clear vision is or visual acuity. So you need to have a pediatric ophthalmologist who knows how to be patient, who has the physical setup to be able to deal with kids with special needs. And in some cases, that means that we'll need to treat them with glasses, things that can correct the vision. In some cases, we may need to do surgery. So if it feels like there's a lazy eye, we may need to do a procedure to tighten up the muscle here on the side to get the eyes aligned back. And sometimes we may need to do patching. So if there's a weak eye and a strong eye, we may need to do patching of the strong eye so that we get the weak eye to get stronger. So these are all things that can be done, again, very effectively, and especially important to start this early. In addition, I think many of you will notice that our children have particular issues that stem from the brain, and they can have effects on the rest of the body, or at least the way the rest of the body works. So the brains can affect the muscles because there are nerves going from the brains to the muscles. And one of the things we see is that the muscle tone is weak. The kiddos tend to be looser, they tend to be floppier, and as a result of that, they may not be able to be quite as strong. They may not be able to run quite as fast, to be able to have as much truncal tone that they can sit up straight. And so sometimes they even get tired. They may poop out before some others do when you're going on a walk in the woods. They also can have trouble in terms of sometimes being not as coordinated. They don't have as much motor memory to remember where their body is in space. They may not be as coordinated. They may be clumsy. They may trip and fall, be prone to accidents. These are all things that we can see. Some of the kiddos have been diagnosed, I would say, before the HIVEP2 diagnosis with CP or cerebral palsy. They may have had muscle tone issues. They may have been tight. Some kids are loose, some kids are tight, some kids are loose and tight, different parts of their body. And some people diagnose them with cerebral palsy thinking that there may have been a birth injury that caused muscle tightness. For all of your kiddos, I will say that they may be tight, they may have hypertonia, but I don't think technically they have cerebral palsy. I think it's fine to use that term as a descriptive term, but I think in many cases it probably was not problems with birth trauma or how they were born, but rather that it's really the HIVE-P2 that's causing these differences. Thankfully, only one person in the group that we looked at had a seizure disorder. In this particular case, the individual had what we call a grand mal seizure, or what we would think of as jerking, maybe movement of the arms and the legs or movement of the entire body. The good news, though, is that this is not very common. And so I think we still need to have some more individuals, especially as they're going through different life stages like puberty. But I do find this to be reassuring that seizures are not a common condition, at least. Um, you might not have thought about it, but the brain is actually connected to your stomach, to your intestinal system. And so in the same way that there can be low muscle tone of, for instance, the trunk or the arms or the legs, there can also be low muscle tone of the intestinal tract. And so many individuals may have problems that things don't go through the intestinal tract in quite the same way. There are what we call sphincters or muscles in the intestine to try and keep food going in one direction. If those sphincters or those muscles have low muscle tone, sometimes things can go back up when they were supposed to be going down. And that's basically what heartburn is. So some of our kiddos have heartburn or reflux. This can be very effectively treated with medication. Some of our kiddos have intestinal issues because they get constipated. Things, again, through the intestine are not going through as quickly. That muscle tone is lower, and so things are slower in terms of transit. And some individuals, they may even have diarrhea as well, or they may alternate between diarrhea and constipation. This is all we think related to the brain and the brain effect on the intestine. I don't think our kiddos have underlying immunodeficiencies or underlying problems with the immune system. I want to emphasize, I do not think that's an issue. But what I do hear with fair frequency is that when our kids get sick, it may take them longer to get better. It may hit them harder. They may have more issues of getting fluid in their ears. And I think people in a good way are attuned to that, so that if they see their child getting recurrent ear infections and they do see that their pediatrician sees that there's fluid in the middle ear, oftentimes we're seeing, and I agree with this, that ear tubes are being placed. That helps to drain the fluid. And if any of you have been swimming this summer, you'll know that if you hear someone talking underwater, if you're underwater when they're talking, you can't hear so well. And it's the same thing when you've got fluid in the middle ear, and that's why we drain that fluid. Again, I want senses coming into the brain. I want people to hear clearly, especially when they're learning how to hear, or rather learning how to speak. I want those words coming in very clearly. I will say this, and I'm going to take 1 second to pause here because I get a lot of questions about COVID. I want to reassure families that in general, children are quite resilient to COVID infection or SARS-CoV-2 infection. In general, they're not getting very sick. They still can get infected, but they're not getting very sick. I worry more, to be honest, about them infecting their grandparents. I'm more worried about their grandparents at this point. There are, and you may have heard about a small number of children that get a rash-like illness. Some have called it Kawasaki. Some have called it a multisystemic inflammatory syndrome in children, or MIS-C. Um, that type of condition oftentimes will be associated with a rash. And I will reassure people that although, and I can say at my hospital, we certainly had children in the hospital with this, we have learned very quickly how to treat this. And it's treated with very accessible, FDA-approved medications, steroids basically, and immunoglobulins that are very effective. So I don't want you to be afraid of your children in COVID. I'm not saying I want anyone to get this infection, but I don't think we have to be especially worried about our HIVEP2 children. Um, Not very commonly, but we have seen some of our kiddos that have trouble in terms of gaining weight or with growing. And that's, I think, a combination of some with some eating issues, being able to coordinate in terms of eating. I've seen families do different tricks in terms of either pureeing food or making it easier, or using some softer food that doesn't quite take quite so much coordination, food supplements, Pediasure, things like that. But we have occasionally seen this. It's not something that I think is devastating or a serious problem, but we do want kids to get good nutrition so that they can be strong and so that they can work through their therapies and be able to learn. Again, it's very rare, only one person, but we did see one person who had some issues. We talked about reflux in the intestine. There can also be reflux in the urine system. So going from the kidneys through the bladder, there can be some circumstances where the urine can go back up, and that can cause some problems. Usually that's very readily treated, but this is something we can see. And one of the things to pay attention to is if your child has a urine infection, make sure that you raise this with the doctor, either the pediatrician or the urologist. Um, Again, and I want to emphasize, I think our kiddos are still young. We're not seeing commonly bone problems. We have seen one person with hip issues, and not just hip issues, when you're 70 or 80, but younger hip issues. Potentially, we want to take care of those and make sure that they don't later cause problems with arthritis. I will say one of the things I'm watching for is whether our kiddos, when they're going through adolescence, have any issues with curvature of the spine or scoliosis. That is a common thing we see in children with neurological conditions and hypotonia, but we haven't seen it yet. I'm going to start wrapping up, but tell you about some of the things that parents have done or that children have had in terms of treating these conditions. I mentioned these in part so you can see that if your child has had some of these, you're not alone, and also to say that there is something that can be done, and to give you a sense of all of these things that I've mentioned here are not too serious in terms of the interventions, the surgical interventions in particular that people have had to take. So tubes in the ear, taking the adenoids out of the throat, doing some of those lazy eye surgeries. Those are the typical types of things we're seeing. And also I want to reassure you, those are typical surgeries that we do in children. So things that I wouldn't say are extraordinary that we've needed to do for the HIVEP2 kiddos. In some cases, children and young people have needed medications to help with things. Some of these are what I would call typical medications. So medications for asthma or allergies, seasonal allergies. I think these are typical. I don't think they're HIVE-P2 specific, but we do know that in some cases, issues again related to neurological conditions, behavior, seizures, attention, those are things that on a consistent basis, individuals are being treated with medicines because number one, the medicines have been helping, and number two, the issues have been significant enough to need medication. So again, at this point, I haven't seen from the families reporting any, sort of wonder drug that's made all of this go away, but there have been medications that have helped with individual symptoms, and for gastrointestinal or GI symptoms, things again to deal with that reflux, constipation, or diarrhea. So just in wrapping all of this up, again, I want to emphasize mostly what we're seeing are things related to the brain, neurological, behavioral, learning issues. They are stable. That is, I'm not seeing folks that, for the most part, are having problems with regression. When people are learning skills, once they really get them down, they're keeping them. And for the most part, when I'm looking at medical issues, serious things like cancer or heart disease or diabetes, so far we're not seeing those. Now, we still have young people in this study. I think we still need to continue following them forward, but I do think this is reassuring. I emphasize these things so that you can take this information back to your doctors, to your therapists, to your teachers. This is all going to be posted online. As we continue to learn more from the community, we will post, we often call them snapshots or summaries of this information. We'll continue making all of this information available in the same de-identified way that we have today. And if there's something that you've seen in your child or in your family member that you didn't see me cover today, do please reach out and let us know. Maybe we're not asking the right questions. Maybe there's something that you've caught in, you have some insight into that we need to focus on more. We clearly have much that we can learn together, so please do help us to be able to fine-tune this study for your community. Finally, I'll say that this heretofore has really been focused for the parents and the families. If any of you are researchers and watching in to learn also about HIVEP2, I want to remind you that you can get access to this de-identified information. The website is right up here at the upper left hand, Safari Base or base.safari.org. And if you have questions, there's a place on the website you can ask questions. It starts out with collections as the email address. And if you get stuck or are having trouble doing this, please let us know how we can help you make sure that as a community, we can learn from each other and we can help you to do your research more effectively. So I'll be glad to stop there and very glad to be invited and to be part of this family meeting.
All right, thank you, Wendy, for that presentation. For all of the attendees, if you do have any questions, you're more than welcome to enter your questions into the Q&A box, which you should see a button for at the bottom of your screen. You also may see a raise hand button if you'd prefer to speak your question out loud rather than typing in the question box. We can handle questions that way, so let us know if you have any questions. All right, we have one that came through. What would your definition of language impairment be? If a child has 50 words or word approximations at age 8, would that be a sign of language impairment?
Sure. That's a great question. So what we've tried to do is use wherever we can comparisons with an age-appropriate individual, and in general for psychological measures, if they're, this is very technical, I realize, but more than 2 standard deviations away from what we'd usually expect to see at that age, then we'd say there's some sort of impairment. What you described would fit the definition of language impairment. On the other hand, one of the things I'll emphasize is that I think many of our children understand much more and are processing the information. So I think their receptive language is much better, and the actual spoken words may be more limited, but I do think there's a lot going on. So do think about ways to be able to, whether it's language in terms of verbal expression, signs, approximations, communication devices, but I think there are many ways to be able to understand what our kids are trying to tell us.
Thank you. And this next question is asking, do all of the affected individuals have intellectual disability or developmental delay?
Yep. So the bottom line is yes. We use a slightly different terminology for individuals when they're younger, when we don't know what their ultimate intellectual capability is going to be. But so far, all the individuals have either delays in their development when they're younger or when they get old enough for us to officially assess an intellectual disability.
Great. And the next question is, my child, who is now 13, has developed cavus foot, high arched foot. Are there any other cases, or should this also be expected?
That's a good question. As I noted, many of our individuals are still young, not quite everyone, but many are still young. What we can sometimes see is if there are problems with muscle tone, either hypertonia, where the muscle tone is too tight. If there's not a lot of good physical therapy, then sometimes those tendons, those end of the muscles can get tight and lead to some problems that we see in terms of the feet and how the tendons in the feet pull on the bones in the feet. So that's not unusual in general for children with neurological conditions. We do try, and many of you I know use orthotics. Orthotics can be helpful in terms of the constant stretching, physical therapy, other exercises that we do, and that can help them from getting quite so tight. But that's not an uncommon, in other words, it is a common manifestation we see across neurological conditions.
Thank you. The next question is, we'd like to know about the 42-year-old. What type of life are they leading, job situation, etc., which I don't know that we have that information.
Yep. So in terms of, I think the question I commonly get asked is, can I expect my child to be living independently, have a job, have a family? One of the things I'll say is there's a lot we don't know. Currently at this point, we are seeing that children have challenges, not unexpectedly from what you're seeing. And so far, at least, I don't know of anyone with HIVEP2 that's living independently, holding a job, having a family. You know, they continue to have supports as they're getting older. There are lots of ways to do this in terms of physically living under the same roof as parents. There are other options in terms of assisted living facilities, but everyone I know of needs some help.
Thanks, Wendy. The next question is, are the number of participants from respondents from this year only?
So the respondents that I reported on are all time, they're cumulative. One of the things that I know may be confusing, and I hope it's one of the things we can sort out, is that a lot of people started this process in terms of registration and then may have gotten stuck at some point, for instance, in terms of getting their lab reports in, or after they've done that, finding the time to schedule. Please do let the family leadership know as just one way of being able to communicate back to us or communicate to us individually, but we are interested in helping to make this process easier for folks because as you're seeing, you know, every person counts. We need to band together in terms of getting and distributing this information to the community.
Great. The next question, what medications have been beneficial for attention, hyperactivity, and behavior concerns? Is there one that tends to work better than others?
Yep. So in terms of things, we haven't seen any, and again, the numbers are small, especially when it comes down to specific medications that people are using. So I don't feel like we have enough information to know. As an example, we only have 2 individuals on medication for seizures, only 3 individuals on medications for any behavior. So I don't feel like we have enough information to say specifically. I'm not seeing in a good way, I'm not seeing, for instance, medically refractory seizures, seizures that no medication touches and people have to be on 2, 3, or 4 medications or things like that. So far, what I'd say is the typical medications, if you're going to a behaviorist, a neurologist, the typical medications that they're using seem to be effective for HIVEP2 as well.
Great. And then you mentioned kids don't regress on skills. Can you elaborate more on that? We are seeing otherwise.
So under COVID, I would say this is a particularly unusual situation. And I am hearing reports from families about either stagnation or just, I think it's largely because the world's upside down and they haven't had their usual routine. They haven't had their usual therapist. They may have lost some skills in that way. What I meant to, by my statements are that there are some conditions that are truly associated with regression. That is, children sort of advance over some period of time, and then they turn the corner and permanently decline and continue declining. That's not the trajectory that I see with HIVEP2. I do realize that it takes some kids more practice, more reinforcement to gain a skill and really, really have that skill as one that they've achieved. And if they don't have enough reinforcement, they may have the skill one day and it feels like they lose it the next day. The other thing I'll say is, as I mentioned with COVID, many of the children I care for who haven't continued to have in-person therapy, or at least not the frequency of the in-person therapy, some skills that I think they were on the way to solidifying, they didn't quite get there. And so they've sort of rolled back down the hill, I hope temporarily. So that's what I've been seeing. If you as families are seeing something else, please do let me know. But in general, what I'm seeing is an upward trajectory.
Okay, and then unless there are any more burning questions from folks, this is the last question. I'm wondering about the kids with anxiety and ADHD. I would have thought the numbers would be higher. Do you think this might be due to the young age of the sample group?
So absolutely, I do think it's age dependent. I do think that as the children are getting older, they're having more behavioral issues. I think early on we're noticing the developmental issues. So absolutely, I do think there's a bias in terms of who we've got data on right now.
Okay, this person wants to know, can you share the oldest age for the kids involved?
Yep. So 42, I want to make sure I got that right, but I'm pretty sure, yes, 42 is the oldest person that we reported. Almost everyone else, though, is still a child, and I will say less than age 10 is most commonly what we have data on. So we are skewed towards younger individuals, in part because that's who's been getting testing.
Great, and that is the final question. So now we're going to move on to the presentation by Dr. Sid. Dr. Sid Srivastava is a pediatric neurologist at Boston Children's Hospital specializing in neurogenetics. His research involves studying different genetic causes of neurodevelopmental presentations, such as autism, intellectual disability, and cerebral palsy, using the multimodal approach of gene discovery, cognitive behavioral phenotyping, and biomarker identification. At Boston Children's Hospital, he provides care to children in a variety of neurodevelopmental and neurogenetics clinics.
Today I'm going to talk about a really important topic, which is attention deficit hyperactivity disorder, or ADHD, as it relates to HIVEP2 disorder. Here is an outline of my talk. I'll present some background information. Next, I'll talk about the diagnosis of ADHD. I'll cover treatment approaches, including what to do when medication approaches fail. First, let's start with some background. As you know, we're still learning more and more about the function of HIVEP2. What we know is that it encodes a protein which binds to the promoter regions of different genes that are important for brain development. This explains why disruptions to this gene lead to a spectrum of neurodevelopmental impairment and challenges, and these include intellectual disability, autism spectrum disorder, hypotonia or low muscle tone, delayed motor development, attention deficit hyperactivity disorder, aggression, anxiety, and so on. I've started analyzing some data from the Simon's Searchlight initiative. There are 10 participants with HIVEP2 disorder with data that I analyzed. In terms of the different types of variants represented by these 10 participants, 8 had nonsense variants, 1 had a missense variant, and 1 had a frame shift variant or misspelling. This graph shows adaptive standard scores from the Vineland on these 10 participants. Think of adaptive scores like self-help scores, self-help skills. There's an overall adaptive score, a score for communication, socialization, daily living skills, and motor skills. The overall adaptive score was 59. A score of 100 is the mean, and one standard deviation below the mean is 85. So a score of 59 is more than 2 standard deviations below the mean. Communication and socialization were relatively higher, while daily living skills and motor skills were relatively lower. I looked at the prevalence of autism that was self-reported among the participants with HIVEP2 disorder in this cohort. It was about 40%. The prevalence of ADHD within HIVEP2 disorder is not really known. However, there was a prior medication survey that was completed by some families. 100% of the respondents said that hyperactive, impulsive, and/or inattentive behaviors are an important target for medication therapy. So I think it is important to talk about ADHD within the context of HIVEP2 disorder. While we don't have a specific targeted treatment for HIVEP2 disorder, at least not yet, we do have some really good approaches to treat ADHD, which may improve quality of life. First off, how does one make a diagnosis of ADHD? ADHD is characterized by inattention, distractibility, hyperactivity, and/or impulsivity. These behaviors start in childhood. They're present in multiple settings, for example, school and home, and they result in performance issues in social, educational, or work settings. You must take into account a child's developmental age. For example, if you have a 10-year-old child who's developmentally at the 5-year-old level, then their attention span should be at the 5-year-old level as well. There are 3 subtypes of ADHD, a predominantly inattentive presentation, a predominantly hyperactive impulsive presentation, and a combined presentation. And keep in mind that the term ADD is no longer in use. There are 9 core types of inattentive symptoms. These include a child who often fails to pay attention to details or make careless mistakes, a child who often has difficulty sustaining attention in tasks or play activities, a child who often does not seem to listen when spoken to directly, and so on. I won't go through each of these in detail, but they're listed on the slide. There are 9 core types of hyperactive impulsive symptoms. These include a child who often fidgets with or taps their hands or squirms in their seat, who often leaves his or her seat in situations where remaining seated is expected, who often runs about or climbs in situations where it is inappropriate to do so, and so on. Again, I won't go through each of these, but they're listed on the slide. The DSM-5, which is a way of establishing guidelines for different neurodevelopmental diagnoses, has established guidelines for the diagnosis of ADHD. In terms of age of onset, there must be several inattentive or hyperactive impulsive symptoms present that occur prior to 12 years of age. These symptoms have to be present in 2 or more settings, such as home or school. And individuals younger than 17 must have 6 out of 9 inattentive or hyperactive symptoms. For individuals 17 years and older, you only need 5 or more symptoms. Symptoms have to be present for at least 6 months, and they must exceed expected level of behaviors based on a child's developmental age. And these symptoms have to interfere with or reduce the quality of social, academic, or occupational functioning. Finally, these symptoms are not better explained by some other diagnosis, such as psychosis or schizophrenia. ADHD is a clinical diagnosis, and this involves obtaining a detailed history to evaluate behavioral symptoms. Often parent-teacher rating scales are needed to get evidence from teachers, and these scales include the Conners, the Vanderbilt rating scales. We often use the DSM-5 diagnostic criteria to make a diagnosis of ADHD. Before making a diagnosis, though, I think carefully if there may be something else going on. For example, is there vision or hearing impairment? If you can't hear or see as well, then sometimes you can appear unfocused, inattentive? Are there sleep problems? Poor sleep is associated with a host of behavioral and other problems and can certainly present as ADHD in some cases, HIVEP2 disorder being no exception. Is there a thyroid problem such as hyperthyroidism? Usually there are other symptoms that go along with this. Could there be seizures, especially a type of seizures known as absence seizures? And usually a good history will help indicate if this might be the cause. So let's talk about treatment options. First off, what are the goals of treatment of ADHD? Here are the goals that we should keep in mind for treatment. So we want to decrease disruptive behavior. We want to improve self-control, self-esteem. We want to improve safety in the community, in school, and the home. Well, we want to improve independence in terms of self-help, in terms of schoolwork. And we want to improve relationships with parents, with siblings, friends, teachers, and so on. There are two approaches to treatment, and often both are necessary. There are non-pharmacological interventions, such as parent training, behavioral therapy, educational accommodations, social skills training. If behavioral therapy is ineffective, medications may be necessary. There are three main classes of ADHD medications: methylphenidate products, which are stimulants, dextroamphetamine products, which are also stimulants, and non-stimulant products. Stimulants are the first-line medications for ADHD. However, there are also a few non-stimulant options. With the diagnosis of ADHD, I often start with behavioral approaches. Here are some general strategies for managing ADHD, some general behavioral strategies. I'll go through each of these briefly. So they include things like modifying your expectations. So being realistic about what your child handles well and what your child doesn't handle well. Identifying success. So if there's a situation that your child does really well in, amplify that situation. Get moving, so encouraging physical activity on a regular basis. Allowing fidgety behavior, so when you're working, so which may help your child pay more attention in some cases. Applying the breaks, so scheduling time for breaks after working on an activity for some period of time. There are also some behavioral modification techniques that may be helpful. I'll go through each of these briefly as well. So this includes things like using simple, specific commands that are one step, not multi-step, and not stated as a question. Using positive reinforcement, for example, giving rewards for good behavior immediately after the behavior, not after a delayed period of time. There's also token economy, which is providing awards after a child accumulates a certain number of stars or stickers. Consequences for negative behavior, so taking away a reward, such as a toy for unwanted behavior. Timeout, and we usually recommend 1 minute per age in a quiet, non-distracting set-aside area. Using visual or auditory aids or cues like a timer that dings to help your child stay on task and help with transitions. Behavioral therapy is an approach that involves structured discipline to reward desired behaviors, such as following directions, and eliminating unwanted actions, such as losing a toy or losing homework. For kids under the age of 5, behavioral therapy is the first-line treatment for children with ADHD. And I've included a link from a parent-friendly magazine below that talks about this in a little bit more detail. Behavioral parent training is another behavioral approach for ADHD. And this teaches parents skills on effective, productive interaction with their kids. The goal really is to strengthen parent-child relationships and build long-term strategies for behavioral management. These programs require 10 to 20 sessions or so, each of which focuses on specific techniques to address problematic behaviors. Again, there's a link below that talks about this in more detail, and this is from a parent-friendly magazine. Behavioral therapy can take time, sometimes on the order of months or longer, but if the symptoms of ADHD do not improve, then medications may be necessary, either alone or in combination with behavioral approaches. Medication treatment can require a trial and error approach, starting with one class of medication and then switching to another because of poor response or side effects. We often start with stimulants as the first-line treatment for ADHD, regardless of whether it's HIVEP2 disorder or another cause. The question remains, are stimulants effective for ADHD? And the answer is yes, for the most part. There was a key study early on that showed that 75% of children show improvement on stimulants. This was the so-called multimodal MTA cooperative group study. Of course, this is not specific to HIVEP2, but included a very heterogeneous population. We have no better medication treatments for ADHD at the moment. There are some simple principles regarding starting stimulants. I recommend a start low, go slow approach, especially because the metabolism of kids with HIVEP2 disorder may be different. I recommend that you wait at least 1 week before deciding whether a new medication or dose change is effective or not. Really avoid the temptation to stop a medication early on unless there are serious side effects. Also, I also suggest starting on a holiday or weekend so that you can observe any effects and any side effects. Stimulants can have various side effects. Side effects include things like appetite suppression, sleep problems, irritability, rebound symptoms as the medication wears off, headache, stomachache, compulsive behaviors, tics. Keep in mind, this does not mean that you will develop all of these side effects. This is just only the range of possible side effects. Sleep and appetite changes tend to be among the more common side effects that you see with stimulants. You do have to periodically monitor heart rate and blood pressure while being on a stimulant. Here are some common questions that people ask about stimulants. For example, some may ask about stimulant use in cardiac monitoring. So stimulants are contraindicated in individuals with structural cardiac abnormalities. So if your child has had an echo that shows a structural heart abnormality, stimulants may not be as a great idea, unless you get clearance from the cardiologist. Otherwise, people who take stimulants undergo regular heart rate, blood pressure monitoring. Another question relates to short stature. Stimulants can cause appetite suppression, which may lead to some weight loss, which can be addressed with simple measures like boosting caloric intake with peanut butter, smoothies, and so forth. A final concern, a common concern about stimulants is tics. Tics are not caused by stimulant use per se. However, tics can be unmasked with stimulant use. Choosing which medication depends on your preference for the duration of the medication and how your child can take medications. Within each class of medication, there are short-acting forms lasting about 3 to 6 hours and long-acting forms lasting upwards of 12 hours. There are pill options, which you can't crush or chew. There are capsule options, which you can open up and sprinkle onto food, yogurt, applesauce. There are chewable pills, which you can chew. There are liquid solutions, and there are also patches which you can apply onto the skin. Let me go through these options, and we'll start with the methylphenidate products. And keep in mind that this list is not meant to be exhaustive, as there are new formulations that come out every year or every few years. So the first category is short-acting methylphenidate products. So this includes things like methylene, Ritalin, and Focalin. Methylene comes as a chewable tab and a liquid, and the others are regular tabs. They take about 30 minutes to kick in. They last 3 to 6 hours, and they're usually given twice a day, though they can be given up to 3 times a day in some cases. Intermediate acting products include Metadate ER, which comes as a pill that has to be swallowed whole. It takes 1 to 2 hours to kick in and lasts about 8 hours or so. It's usually given once a day, but you can give it twice per day in some cases. Long-acting products include things like Ritalin LA, Metadate CD, Concerta, Daytrana, Focalin XR, Coolivant XR. Ritalin LA, Metadate, and Focalin XR come as capsules that you can open up and sprinkle onto food. Daytrana comes as a patch. Coolivant comes as a liquid. Focalin XR comes as a capsule, as I said, that you can sprinkle onto the food. Focal XR has the shortest onset of action. It kicks in about 30 minutes or so. And in general, these medications can last 7 to 12 hours per day, depending on the medication. And they're usually given once per day. In terms of the amphetamine products, short-acting versions include Adderall, Zenzity, and Procentra. The first two, Adderall and Zenzity, come as pills, and Procentra comes as a liquid. They kick in about half an hour. They last anywhere from 4 to 8 hours. They're given once a day, up to 3 times a day. Intermediate acting products include dexedrine spanchules, which come as a pill form. It kicks in 1 to 2 hours and lasts 6 to 10 hours. It's given once to twice per day. Long-acting products include Adderall XR and Vyvanse. Adderall XR comes as a capsule that you can open up and sprinkle onto food. Vyvanse comes as a capsule and a chewable version too. Adderall XR takes 30 minutes to kick in and lasts 10 to 12 hours. Vyvanse takes longer to kick in and lasts a similar amount of time. Both are given once a day. In most cases, ADHD can be treated without the use of a second-line agent. In some instances, though, the use of a second-line agent may be necessary. For example, there may be suboptimal effect or adverse effects with the use of a stimulant. In children who are especially young, I sometimes consider starting with the second-line agent first. And finally, some family members prefer their child not be on a stimulant for ADHD. Side effects of non-stimulants can vary depending on the medication, but some examples of possible side effects include sedation, dry mouth, GI symptoms, low blood pressure, low heart rate. Depending on the medication, you may have to monitor heart rate and blood pressure. Here are the non-stimulant options. Short-acting options include guanfacine and clonidine. They come as pills, which are given 2 to 4 times a day. Each dose lasts anywhere from 4 to 8 hours or so. Keep in mind it takes a couple of weeks before you notice improvement in symptoms. Long-acting options, non-stimulant options, including Cafe, which is clonidine extended release, clonidine patch, and Intuniv, which is guanfacine extended release, and Strattera, also known as atomoxetine. Each dose of Cafe lasts 12 hours or so and can be given up to twice a day. Clonidine patch is applied on a weekly basis. Intuniv can last up to 24 hours and is given once a day. Strattera lasts also about 24 hours. Again, these medications can take a couple of weeks before you start to notice an effect. A common question that comes up in HIVEP2 disorder is whether you can do pharmacogenomics testing to see if your child will respond to a certain class of medications. Unfortunately, for ADHD medications, there are no published guidelines to guide dosing and product selection. So without such guidelines, recommendations with this testing are based on other factors such as response to prior medications, and these recommendations may not be strong recommendations. What about non-medication options for treatment of ADHD? I've listed a few here, listing the treatment, side effects, and whether they're effective for ADHD. Omega-3 fatty acids, which are a component of Viarin, are associated with side effects that are GI related namely. Data about its efficacy in ADHD are inconclusive, though some studies have shown benefit. Medication, of course, doesn't really have much side effects and is also dependent on the cognitive level of your child. Its efficacy for ADHD is also inconclusive. Exercise actually does seem to benefit the core symptoms of ADHD, so something to keep in mind. Neurofeedback, also known as EEG biofeedback, does not really seem to show benefit for ADHD. And then CBT, or cognitive behavioral therapy, may be helpful for some adults with ADHD, also who are higher functioning, who have the cognitive capacity to participate in CBT. In general, more studies are needed for this, though. What about certain vitamins and minerals? Do they help for ADHD? There is one double-blind placebo-controlled study that has shown that zinc as an adjunct to stimulants may be beneficial, but not zinc by alone per se. Ferritin levels, which are measures of iron stores in the body, are lower in children with ADHD compared to controls, but this does not mean that you should start iron if you have a diagnosis of ADHD. In general, there's not really great evidence to support use of specific vitamins or minerals for ADHD. So does nutrition impact ADHD symptoms? So while there isn't a lot of evidence that changing your diet can improve ADHD symptoms, we do know that certain nutrients are important for brain health in general. There's a link to a National Geographic article that talks about this in more detail. Multiple nutrients are important for brain health: protein, zinc, iron, choline, folate, iodine, vitamins, omega-3 fatty acids. And examples of foods that are rich in these components include things like fish, oats, nuts, citrus fruits, berries, plums, sweet potatoes, other vegetables of different colors. So one of the challenges that comes up is what to do when ADHD medications fail. So what could be going on? I'm going to present 4 sample cases vignettes of individuals who are not responding to ADHD medications and what could be going on or what else we should consider. And I want to give a shout out to my mentor at Kennedy Krieger, Dr. Bruce Shapiro, whose slides I adapted for this portion of the talk. So the first case is a 5-year-old boy with HIVEP2 disorder and a new diagnosis of ADHD due to hyperactive impulsive symptoms. He was started on methylphenidate and the dose was optimized, but there hasn't really been any symptom improvement. Not surprisingly, his language was delayed. He requires speech and language therapy. So this is a really simple example, but the point I want to raise here is, do we have the correct diagnosis? Not all hyperactivity is ADHD. Hyperactivity can be due to cognitive learning disorders such as intellectual disability, language disorder, specific learning disabilities, especially if these are not recognized and treated appropriately. Anxiety can look like a lot of things in young children. It could look like ADHD. Mood disorders like depression can sometimes appear as behavioral dysregulation that can mimic ADHD. And as I mentioned earlier, it's really important to consider the possibility of a medical problem like hearing loss, trouble sleeping. So let's talk about case 2. So Isaac is a 6-year-old boy who has HIVEP2 disorder and a diagnosis of ADHD. He started taking Concerta, which is a long-acting stimulant, but did not continue it due to moodiness. He then started Ritalin, which is a short-acting stimulant, which had good effect initially. This past year, he started a full-day program, and the Ritalin no longer seems to be effective. So what could be going on? In this scenario, I think the key question is, are we observing behaviors during peak action of the stimulant? Short-acting stimulants can take 30 minutes or longer to work. They last anywhere from 3 to 6 hours, give or take. Dosing is usually twice a day. Ideally, one would want a smooth overlap between the waning effect of the first dose and the rising effect of the second dose. So this is the graph on the left. The situation you want to avoid is the graph on the right, in which the second dose is started when the first dose's effects have fully escaped. So it's out of your system, and then you start the second dose, and there's not that nice overlap that you want. And so that might be what might be happening in this scenario. Some individuals are fast metabolizers, and each short dose of stimulant may last only 3 hours, for example, much shorter than the usual 4 to 6 hours. And this may be possible in HIVEP2, and the opposite may also be possible. In other words, it's really important to assess the timing of symptoms during medication management. So let's move on to case number 3. So Vanessa is an 11-year-old girl with HIVEP2 disorder diagnosed with ADHD at age 7. She started stimulants with an excellent response. This year, after starting 6th grade, she's faced increasing difficulty in school. The first question I would ask here is, are there compliance issues? On the parent side, some parents are unsure about their decision for giving their child stimulants and may be giving medication inconsistently, which may lead to inadequate treatment effect. If the parent is trusting that their child is taking the medication on their own, once again, the caveat is this depends on the cognitive level of your child, whether that's feasible or not. So that might pose challenges. On the child side, the child may not want to take medication, saying there's nothing wrong with them. Once again, this may also be contingent on the cognitive level of the child. They may be having side effects and they may be deterred from taking medication. In some cases, in older individuals, and also depending on the cognitive level, there may be some diversion happening. It's really important to note that certain medications have to be taken a certain way, and doing so incorrectly can lead to unpredictable responses. Another really important question to ask in this scenario is, do we have the right expectations? So it's really essential to match the capabilities of the child with the demands of the situation. And what I mean by that is, if the child is at the 3rd grade level academically, but is being taught at the 5th grade level, or whatever you want to say, whenever there's a mismatch between those two, however large, that can cause behavioral problems that appear as ADHD. In addition, school demands change throughout the years, and there may be increased demands for organization, working memory, other executive functionings, such as requirement for more writing, chapter reading, schedules, and other things like that, also dependent on where the child is cognitively. So here's the final scenario. So Emily is a 6-year-old girl with HIVEP2 disorder, recently diagnosed with ADHD. Her parents were initially reluctant to start stimulants, but they were impressed with the initial effects. And during the titration period, they pushed to increase the dosage. And after an initial period of improvement, she seemed to revert to her previous behaviors. The question I would ask here is the medication timing dose optimized? The dose might be too high and can be titrated slightly down as one solution. There are many ways in general to tweak a medication so that we have the right drug, the right dose, the right duration of action, the right delivery system. The key point is, don't give up. I wanted to wrap things up with some considerations across the lifespan when it comes to ADHD. In the preschool age, the focus really is on diagnosis. Do the symptoms fit a diagnosis of ADHD, or could there be something else going on? Safety is really important. I generally don't start medications in the young preschool age for ADHD unless there are safety concerns and or significant parental distress. In the school age, so this is the time to think about whether the child needs certain accommodations and may get by with just a 504 plan or would need more support, such as with an IEP, which would be preferable for kids with HIVEP2 disorder. This is also when friendships start to blossom. And keep in mind that kids with ADHD can have social impairment too, because they may not be paying attention to social cues, for example. During academics, during adolescence, academics are of course a huge concern. So if standardized testing is something that may be a possibility for a child with HIVEP2 disorder who's higher functioning, then getting extra time requires neuropsych testing and other logistics before it may be approved. And kids with ADHD can be impulsive, and this can amplify some of the risk-taking behavior that occurs during adolescence, so you have to be mindful of that. And in adults, so once again, depending on the child, the adult's cognitive capability, jobs and family may be two things that come to mind. In general, 50% of individuals continue to need stimulants in adulthood, and disorganization can be a challenge for adults, which may affect both of these areas, and also, once again, contingent on the individual's cognitive level. So let me wrap this talk up with some conclusions. So ADHD can be a challenge for individuals with HIVEP2 disorder. There are a number of treatment approaches, including medication and non-medication approaches. medication approaches may require a trial and error process. And the goal of treating ADHD symptoms is really to improve functioning life, how the child interacts with everybody, how the child functions in the school, home, and other settings. Finally, I would like to thank Nurse Ramsey and all the other HIVEP2 families, Dr. Wendy Chung and the rest of the team at the Simons Searchlight Project, and Dr. Mustafa Sahin, who's my mentor at Boston Children's Hospital. Thank you.
All right, and just like last time, any questions you have for Dr. Sid, go ahead and put them in the Q&A box and we'll work on getting them answered. We are a little ahead of schedule today, so we have plenty of time for questions. Okay, the first question here is, given some HIVEP2 kiddos present seizures, is there any worry of developing seizures trying ADHD medications? Also, what GI symptoms were reported with trying omega-3?
Sure, that's two great questions. So there's a lot of, in the past, there's been a lot of concerns about use of stimulants in children with seizure disorders or epilepsy. However, recent data has shown that it is safe to be on a stimulant, even if you have a diagnosis of epilepsy. So for children with HIVEP2 disorder who have epilepsy or a seizure disorder and who also have ADHD, it is safe to be on a stimulant medication. In other words, being on a stimulant does not endanger the child or increase the seizure risk. So regarding the second question, so the types of GI side effects include things like nausea, vomiting, and those kind of side effects.
Thanks. We don't have any additional questions yet, but we'll just wait a few moments and see if any more questions roll in.
We do have a hand raised.
Oh, sorry, I missed that. Okay, it looks like Mark has his hand raised. So Mark, you can now unmute yourself and ask the question. You can unmute yourself by clicking the mic button in the lower left screen.
Sorry, we're having trouble like finding the question box again. I'm just wondering if there are any long-term effects, or any effects for having our child's on methylphenidate and has been for a couple of years now. Is there any worry of any kind of consequence from being on that for multiple years? Is it something that we should think about switching to it and trying another stimulant? We're not even 100% that he has ADHD. He's never had any type of hyperactivity, but it does help with his focus, I feel like.
Great. So that's a great question. So there are two parts to that question. I think the first part is, what are the long-term effects of being on stimulant use? And in general, stimulants, stimulants are safe, including on a long-term basis. I think the question specifically about in terms of long-term use in children with HIVEP2 disorder who are on stimulants. I think that remains a question just because we don't have that data yet. From the literature on children, a heterogeneous population of children, meaning children who are otherwise have no underlying genetic disorder or who have varying other conditions. So a heterogeneous population of children with ADHD, in general, stimulants are safe for long-term use. But we of course need a lot more data on these type of medications in children with HIVEP2 disorder specifically. But in general, I think it's a safe long-term option. And the second part of your question alludes to, well, should my child be on a stimulant, or how do we tell if it's working or not? And I think that's it's a lot of factors. One is kind of subjectively asking yourself, your family members, your school, the therapists who work with your child, do they notice an improvement or not? And so that's more of a subjective feel. And the second is getting objective data. So we often use checklists such as the Vanderbilt checklist or other type of checklists that quantify behaviors, and we'll do so before we start a medication and then periodically after starting a medication. And sometimes those numbers, that objective data, can tell us, oh, we do see improvements in these number of symptoms. Other examples of behavioral objective data, including sometimes teachers will track performance and quantify performance, and you may notice, oh, being on a stimulant has led to X percentage improvement or so forth. So it's a good question, and it's always good to have a good outcome measure if the medication you're on, whether your medication that you're on is effective or not.
Thank you. Okay, the next question we have is, our pediatrician suggested my son take Risperdal. We did not start the medication. He is 3.5 years old.
If I may extract, perhaps the question is about, should we try Risperdal? I guess, would that be the question?
I think so, yes.
So Risperdal is a neuroleptic medication. So what that means is, so it's a type of medication that is used to target aggression, irritability associated with the diagnosis of autism spectrum disorder. And it's a strong medication, meaning that it is effective for those type of symptoms, meaning the aggression, and for the kind of autistic irritability or irritability associated with autism spectrum disorder. But on the same side, on the flip side, it also has potential for side effects. So these side effects include disruptions to blood glucose level, blood sugar level, cholesterol levels, and other metabolic side effects. So in this case, I think I think the two things I would ask is, one, is the medication, is the Risperdal being used to target those type of symptoms, meaning aggression or irritability associated with autism? So that would be the first question I would ask. The second question I would ask is, well, if there is aggression or irritability, or let's just say aggression, then have other medications been tried first? And those other medications would include some of the non-stimulant medications I mentioned, such as guanfacine or clonidine. And the reason I say that is because guanfacine and clonidine or other types of those category of medications have a milder side effect profile than Risperdal or other types of neuroleptic medications. So to summarize, what I'm saying is that, one, make sure, so the first question is there aggression? Is there significant irritability associated with the diagnosis of autism? Are those core symptoms? Oh, sorry, go ahead.
Just really quickly, they chatted again and said that there is no aggression and still no diagnosis for autism.
Okay. Yeah. So I would just clarify, what is the target symptom that this medication is being used for? Often the scenarios are complex. And then the second kind of big theme is, are there other alternatives we could potentially try before going to Risperdal? Because as I said, it's effective, but has a significant side effect profile, or potential for a significant side effect profile.
Thank you. The next question, what is your opinion about combining Metadate CD and guanfacine?
Yeah, so often in children with HIVEP2 disorder who have ADHD, who have not responded to being on one type of medication, meaning a methylphenidate product or amphetamine product or a non-stimulant, the combination approach sometimes can be helpful. So if the individual has tried, a methylphenidate product and wasn't successful, and then tried a dextroamphetamine product and wasn't successful in that trial, and then tried a non-stimulant and wasn't successful in that trial, then sometimes a combination of a stimulant and a non-stimulant, as is the case, may be an effective course.
Thank you. And now, how commonly is ADHD associated with intellectual disability and developmental disabilities? If children have ADHD symptoms but also have developmental disabilities, does medication seem not to work as well?
Yeah, that's a great, really great question. So what I would say to that is that it's really important to get a sense of where a child is functioning developmentally. And the reason why that is important is because if the hyperactivity or inattention are as you would expect for that child's developmental level, then I would argue perhaps that's not really ADHD. That's just kind of the expected attention span and expected focusing for the child's developmental level. So as an example, so if you have a 10-year-old child with intellectual disability, and let's say that 10-year-old child IQ is 50. So a 10-year-old child with an IQ of 50 is functioning at about 50% cognitively, so is functioning at around the 5-year-old level. So once again, 10-year-old child, IQ of 50, functioning at the 5-year-old level cognitively. If their hyperactivity, if their attention span, focus, and behaviors are also at the 5-year-old level, then that I would argue that's probably not ADHD. I think that's just what you would expect for the degree of intellectual disability. However, on the flip side though, sometimes it can be very difficult to tease apart what is the expected attention span and focusing of a 5-year-old level. Or, as you get lower in age, then sometimes the question is, well, what is the normative or what is the typical attention focusing abilities for that developmental age? And sometimes that's a tricky question to argue. So to summarize, in general, with intellectual disability, ADHD is a common comorbid or co-occurring diagnosis that we see. In some cases, I would argue that in some cases, it may be the case that the behavioral symptoms may be expected for degree of intellectual disability, but of course, each scenario is different. It really depends on the specific scenario for each child.
Thanks. So the next question is, how commonly is ADHD associated with intellectual disability and developmental disabilities? Oh, sorry, I'm rereading the question I just read. I'm so sorry. Okay, so this question I think came in a few different ways, so I'll try to get the spirit of it. Their child has worse behavior at home versus when they're out of the home, and they're wondering, is are ADHD symptoms visible in all social situations, or can they be worse at home rather than with strangers?
Absolutely. So the question, if I'm interpreting correctly, is could the manifestations of an ADHD diagnosis differ in different settings? And the answer to that is yes, meaning that it depends so if there's a structured, sometimes having a strong structured learning environment can help minimize some of the symptoms, and having less of a structured learning environment or less of a structured environment can unmask some of the symptoms. So if, for example, if the home, in general, our homes are less structured than school environments, there's often quite a good amount of structure that is happening in the school versus at home, but just that's what is the case, for most families. Sometimes you can see differences in behaviors in one environment versus the other. And so I'd argue, well, one possibility is to try to increase the structure that is taking place in home, and, to make it similar or a little bit more similar to the structure that may be occurring at school. An important thing to note is that if there is a significant difference in the symptoms in home versus school, meaning if school is saying the child is, he or she is behaving really well and there aren't major concerns, versus there are much more concerns at home, then I would argue maybe the diagnosis of ADHD may not be we should reconsider that or see what else may be going on. The reason being is that if this is a diagnosis of, if it is truly ADHD, then it should in theory affect multiple environments, meaning the home and the school environment significantly.
Okay, great. And the next question is just asking, they think maybe they missed it, but did you mention, would you try a non-stimulant versus a stimulant initially for younger kiddos? And then what is the definition of a younger child?
Sure, that's great. So, for children who are, let's say, 5 to 6, who are under 5 to 6 years of age, I would consider, I sometimes consider starting a non-stimulant first. And so that's the age question. Stimulants, there are certain stimulants that are FDA approved for children as young as 3. So it's not that you can't use a stimulant. I think it's more so kind of personal preference and practice, and also comfort level of the family. So I would say 5 to 6, around 5 to 6 is roughly kind of what I would consider young age. And under 5 to 6, I would have a discussion, with the family, whether they would prefer to do a non-stimulant as a starting point.
Thanks. And what are the types of GI side effects from non-stimulants?
Similar across, generally speaking. So also you can see stomach upset, bellies hurting, sometimes nausea, vomiting. So non-specific GI side effects.
Thanks. And then I have a couple questions here about just asking about CBD or other alternative methods, if there are any studies with CBD in this population.
So there's a lot of interest in CBD in multiple neurodevelopmental disorder populations. So there's interest in autism and cerebral palsy and epilepsy and multiple other populations. There's no data, and to my knowledge, I don't know of anyone who's studying CBD use in HIVEP2 disorder specifically. So I think we don't have enough data yet to support its use, or to see if it's effective, to see if there are adverse side effects. So it's an ongoing story. I know there's a lot of interest. The one thing I'll say about CBD is just if you are on CBD, making sure that CBD can interact with other medications, including anti-seizure medications. So if your child is using CBD and is also on anti-seizure drugs, then make sure that make sure there's a monitoring of those levels of anti-seizure drugs.
Great. And then unless we get any other questions coming up in the next few minutes, this is the last question we have. Is HIVEP2 a condition that gets better, or does it get worse as the child gets older?
Yeah, this is, I think Dr. Chung had also alluded to this. This is a non-progressive condition, generally speaking. And what I mean by that is that you're not expected, there's not expected to be loss of skills or regression. On the contrary, that your child is expected to continue to gain skills over time, albeit at their own trajectory. With that said, though, sometimes there can be regressions, such as, or plateauing of skills, or sometimes loss of skills in certain settings. So for example, in this current COVID-19 environment, when children are not receiving in structured learning environments, in classroom structured learning environments, and not receiving consistent educational routine, there can be loss of skills that were previously developed. And what I like to say is, for any genetic disorder, there's always going to be exceptions. So this, what we know to the best of our abilities is that this is a non-progressive condition without regression for the most part, but we're always open to hearing about exceptions.
Hi, I'm Narissa Ramsey, and just wanted to represent the HIVEP2 community in saying how grateful we are for the Simons Foundation and the annual conference. We're really looking forward to hearing from all the great speakers. And I wanted to share a little bit about our community. So here's some of our great kiddos from the HIVEP2 family. As of today, I'm aware of 76 cases across the world. A lot of us are connected in the HIVEP2 Facebook group. And we've got a lot of families in the United States, some in Canada, some in South America, a lot of families in Europe, a few families in Australia, and grown quite a bit from when there was just one case in the United States back about 5 years ago. So with that, I just wanted to give an introduction from some of our kiddos who wanted to say hello. This is Brayden, who's 8 years old, lives in Scotland, and loves Paw Patrol, ice cream, dogs, and his trampoline. And this is Pierce, also 8 years old, from Toronto, Canada, who loves dogs, swimming, and especially hockey. This is Ryan, who's 11 years old now, from Maryland. Also loves ice cream, swimming, and America's Funniest Videos. Here's Amy Rose from London. She's 6 years old. Also loves water, dogs, ice cream, and baby dolls. This is Kaylee Ray, 5 years old, from Concord, California. She loves Oreo cookies, anything rainbow, swim, dance, and she's obsessed with the iPad. Here's Melvin, who's 11 years old, from Sweden, who also loves water, piano, horses, and dogs. Jordan from Australia, who's 11 years old and loves camping, fishing, riding his adaptive bike, and watching police shows. This is Maddox, who's 4 years old, from St. Louis, Missouri. He loves playing with toy cars and water and excels in making messes. This is my son, Curran. He's 6 years old now. We live in Florida. He's obsessed with watching the mail lady, garbage trucks, and jousting. And this is Sam, who's 12 years old, from Salt Lake City, Utah. He has the best smile, the kindest heart, and is an absolute sports fanatic. So I just wanted to share some of our beautiful faces and welcome all of the families and express our deepest appreciation for all of the work that's gone into studying HIVEP2 and helping us learn from the presentations and the information that gets passed on to all the scientists and the publications and information that comes out of this effort. So on behalf of the HIVEP2 community, thank you, and we look forward to hearing from you guys.